Uh, okay, we'll start. Um, so today I thought we'll first start off with some CVS SCQs as revision for the week last week, and then we will continue on with the CKD discussion. Okay. So I'll start with this SCQ. A 68-year-old female presents with 2-hour history of severe central chest pain. She has a history of hypertension for 15 years and diabetes for 12 years. Her compliance for treatment is poor and she's a non-smoker. So on examination, she is in severe pain and sweating profusely. Her pulse rate is 98 beats per minute and regular. Blood pressure is 160 by 100. Her CVS system examination is unremarkable. So what is the most likely diagnosis? So usually this is how they start off any SCQ question in medicine. They usually give a scenario and then they ask the diagnosis. So the point here is to make the diagnosis as completely as possible. And that's why they sometimes even allocate 10, 15, even 20 marks sometimes for a diagnosis. So that means it's not about just mentioning a few words. I mean, it's just not about mentioning the whole diagnosis. You have to give a complete picture about the patient in the diagnosis. So as you're, from this history, it's pretty clear. So severe central chest pain with autonomic symptoms like so sweating is most likely it's likely to be an acute coronary syndrome. Like one might ask the question, okay, why not be a STEMI or NSTEMI or unstable angina? So all those things are ECG diagnosis. So NSTEMI, STEMI, unstable angina, those are ECG diagnoses. So we have not got any ECG findings here. We just got a clinical picture with some symptoms and examination findings. Hence, we can only say this is an acute coronary syndrome and not the latter like STEMI and STEMI or unstable angina. So that is not it for the diagnosis. So they have mentioned certain other things about this patient also. So it's better to include those things also in the diagnosis of the patient. So I would say this is a patient presenting with acute coronary syndrome in a background of poorly controlled hypertension and diabetes. Okay, so that is a complete diagnosis for the patient. So similarly, you guys can apply this to any of the other medicine SCQs also. So try to include it, try to include everything about the patient in the diagnosis. Okay, so you can even, if the rhythm was something, the pulse rate was tachycardia somewhere around 120 and the rhythm was irregular, you can say this patient is also presenting with acute coronary syndrome complicated with an arrhythmia in a background of hypertension and diabetes or blah, blah, blah. Okay. So what is the immediate investigation that should be performed? Okay, so this is also a very another common question in any medicine SCQ. They will ask, okay, after the diagnosis, they may ask what are the, here they ask only one investigation, but there are certain instances they will ask, okay, what are the investigations that can be done in this patient? So for that, the best way is to have your own list of investigations for a particular system. Now, for example, now we know this is from the cardiovascular system. So it is better to have a list of investigations, for all cardiovascular pathologies. Okay, so this is a list I have. So when we take for blood, blood investigations for the cardiovascular system, there we can use the full blood count to check for anemia, cardiac enzymes, lipid profile, and fasting blood sugars. And when it comes to imaging modality, ECG is electrical imaging modality of the heart. So that is investigation, echocardiogram, chest X-ray, coronary angiogram. And then there are these other investigations which are also useful but not routinely done, such as BNP, ABG, and even TSH. Okay, because patients with presenting with acute coronary syndrome can have thyroid thyroid hormone level abnormalities. So, but here in this question, so what is the immediate next investigation that should be done? It's definitely a 12-lead ECG with a rhythm strip. Okay. So then list 3 other differential diagnoses for this presentation. So anyone Anybody presenting with severe central chest pain, you have to entertain certain differentials. So aortic dissection, pulmonary embolism, GORD, things like that. Okay. So outline the management of the diagnosis you mentioned in 1.1. Okay, so when we talk about management, it's always good to have a problem list before we address the management. Okay, so some of the problems I have identified in this patient is, one thing is the acute coronary syndrome, so that's a problem, and the other thing is the hypertension, and the other thing is the diabetes. Okay, now when we have identified the problems, then we can categorize these problems into which requires acute management and which requires more sort of long-term management. Okay, so in this situation, the acute coronary syndrome requires immediate management, and some long-term management things are this hypertension and diabetes. Okay, so in your answer, you can write, you can even write, so problems identified in this patient are these. Okay, and for that, for these problems, this will be my management. Okay, so I have divided into emergency and long term. So any emergency management, you talk about first the setting where you're going to manage the patient. So I preferably this patient should be managed in a high dependency unit setting, and always it's good to follow the ABCD protocol. So oxygen via face mask, you all can remember 2 liters of oxygen via face mask. Connect the patient to a multi-parametric monitor. Cannula, put a cannula in, take blood for investigations. So the blood for investigations in this case will be all those investigations which are relevant for an acute coronary syndrome. And then in an emergency setting, it's always about how you position the patient and how the drugs which are used. So you guys already know which drugs are used for acute coronary syndrome. So you will get more marks if you know the correct doses and the route, things like that. And you can say ECG diagnosis will dictate further management. So you can write, you don't have to write everything. If you are, you can write, okay, if the patient it can be transferred, if the ECG diagnosis is STEMI, the options are PCI or thrombolysis. So if the patient is presenting to a PCI capable center, then within 60 minutes you have to carry out PCI. If the patient can be transferred within 120 minutes to a PCI capable center, then transfer. And or you can write the answer for thrombolysis. Okay. And at the same time, so when these things are done, we have to think about the blood pressure and blood sugar levels in this patient and make sure they are in the normal limits. And also we have to talk about checking for improvement, basically the reperfusion. So the ACS long case we discussed, there are certain things checking for what we check for reperfusion. So you all can mention a few of those and then anticipate complications like heart failure, shock arrhythmias. So it's not like, I understand that sometimes like there is no time to write about each and everything in detail, but I sometimes feel like rather than writing a detailed answer to a particular certain aspect, it's better to mention these things like give a broad idea. So you are telling the examiner that you're thinking about everything, every possible thing in the management of this patient. Okay. So so basically what you should mention is about the drugs, the doses, and about the further management, whether it's a STEMI or in-STEMI, and thinking about you're telling the examiner, you're thinking about the patient's blood pressure and the diabetes, and then you're thinking about the signs of complication, and you're also thinking about how you can, what are the symptoms and signs of improvement in this patient. Okay, and then mention a bit about the long-term management. So always when it comes to long-term management, talk about the multidisciplinary team approach in a specialized center, and then non-pharmacological and pharmacological strategies. So when it comes to non-pharmacological strategies, always talk about first education and educating the patient, because this patient clearly needs to be educated on drug compliance and the importance of that. And then the exercise, smoking, alcohol, all those, usual things, stress management, reduce salt intake, all that. Okay. And the pharmacological management also, there are certain drugs which are given after an acute coronary syndrome. All those drugs should be given at the same time. Drugs to control the diabetes and hypertension also should be given. So you might not have time to write in detail about each and individual point, but just mention these, because I think more they have in the question they have clearly mentioned you just need to outline the management. So outline means give a broad idea of everything. So if you mention these points, you will definitely get marks because the examiner knows you're thinking about these things, which are important in the patient. Okay, like you all like sometimes you might write everything about a very good detailed emergency management and then completely forget about the patient's long-term management. So then the management is incomplete because you have only thought about one aspect. You have only thought about the question at the face value. Okay, you have to think more. So that comes with practice. So you guys will have, I mean, keep writing SEQs and keep thinking about the broad aspect of the patient management rather than thinking about just the current problem. Okay. Okay. So list 3 possible complications of the diagnosis you have mentioned. So after any acute coronary syndrome, they are prone to get any arrhythmias like VT or VFib. They can go into cardiogenic shock, and then they can get all these types of murmurs, mitral regurgitation. They can get VSDs, things like that. Okay. So basically, this SCQ basically covers most of the ACS questions that can be even asked in a long case. Okay. So you guys should keep on practicing SCQs, and most important thing is to refine your answers every day. Okay. We'll do another question. A 66-year-old female is brought to the emergency unit with shortness of breath and chest pain for 1 hour. She's a diagnosed patient with stable angina, diabetes, and hypertension. 2 days ago, she was treated with analgesics for back pain. So on examination, she is afebrile. BP is 190/100. Pulse rate is 112. JVP is not elevated. There is no ankle edema. She has bibasal crepitations and saturation is 88% in room. Basic investigations are shown below. So ECG shows inferolateral ST depressions. CBS is 430, CRP is 8, HB is 7.6, and WBC is 7.8. So they have given a lot of information in this question. Okay, so and there are several problems in this patient that is to be identified by the candidate writing the paper. So now they are asking what is the most likely diagnosis. Okay, so now what are the possible things that what are the symptoms this patient has now? She has shortness of breath and chest pain for 1 hour, and she already has some already diagnosed conditions, and they talk about something about analgesics given for back pain. And on examination, you can clearly see her blood pressure is elevated. She's tachycardic. However, she does not have any JVP is not elevated or no ankle. But she has bibasal crepitations and saturation is 88%. So now you guys have when you guys read lecture notes, the whole point of having lecture notes is to identify the pathology. When they give a certain set of symptoms, it corresponds to a certain pathology. So these things like bibasal crepitations and shortness of breath on this thing for 1 hour. So this clearly seems like some heart failure is going on, right? And they clearly mention that JVP is not elevated and there is no ankle edema. So I think Sriranta really explaining this heart failure presentation that when the right side system is involved only, you get this ankle edema and this JVP business going on. So when the when there's a left ventricular failure only, you get these bibasal crepitations. So it seems like this patient is having a left ventricular failure, but that is not it. That is not the end of the story, because her ECG shows that there are inferolateral ST depressions. So there is some electrical disturbance going on in the heart, and it seems to be a acute coronary syndrome. It's not a STEMI. It can be an in-STEMI or unstable angina. Okay. So how did we come to the conclusion that she has an entity of heart failure is through the shortness of breath and the bibasal crepitations? Okay. And another important clue is that she was treated with analgesics for backache. So one cause for heart failure is NSAIDs. one important cause for heart failure is NSAIDs. So that is also a clue to tell that, okay, this patient has an entity of heart failure. So then what are the things positive for acute coronary syndrome, or in this case, an STEMI or unstable angina? So she has chest pain for 1 hour duration. She is a previously known patient with stable angina, and he has been having diabetes and hypertension. And there are changes, and most conclusive evidence is there are electrical changes in her ECG. So what is the complete diagnosis given? We have to say, okay, this is a patient with acute left ventricular failure, most likely precipitated by an STEMI or unstable angina and analgesic use for 2 days in a background of stable angina, diabetes, and hypertension. Okay. Even if you want more marks, you can add she is actually in a hypertensive emergency because her BP is more than 180 by 100, 180, right? The systolic is, so this is like 190 by 100 is technically a hypertensive emergency. Okay. So acute left ventricular failure precipitated by STEMI or unstable angina or NSAID use and along with a hypertensive emergency. So if you guys can add all that, it will be a very complete diagnosis. So the examiner knows you have identified all the problems they have listed, given in this patient from the diagnosis itself. Okay, so list 4 precipitating factors for the diagnosis given. If you look at, so I mentioned one is the analgesic use, and the other one is she is an anemic patient. Okay, and even sometimes the left ventricular, and another precipitating cause is the STEMI or unstable angina or acute coronary syndrome. And another cause is elevated blood pressure. So hypertension urgency can result in a hypertension emergency. Okay. You have got that point, right? So when they are, now these SCQs are very refined. Okay, like there is a purpose they are asking all these questions, and the answer is there in the question itself. It's just that we have to cultivate the ability to identify the clues they have given in the question itself, identify the clues they have given in the question and apply to our answers. Okay. Okay. So list 5 other investigations that you would perform on this patient with reasons. So I told you, like, so this is again a question from the cardiovascular system. And there are, you guys have a list of, a list of investigations only just for the cardiovascular system. And from that, you guys sweet pick which investigations are applicable in this patient. So now this patient has a heart failure. This patient is having ACs. This patient has a hypertension emergency. So what are some investigations that you can do? So for the heart failure, definitely you need to do a 2D echo. You can do even a BNP also if you like, it's okay. And for the ACS, they have already done an ECG. So after an ECG, what do? You have to do the drop-by levels to differentiate between STEMI and unstable angina. You have to do the drop-by levels. Then also you can maybe do investigations like ABG, chest X-ray. Okay, so mention 5 investigations. These 5 investigations, and you will get marks. Make sure to mention the most important investigations first. Okay, so here most important investigations are the drop-by and the 2D echo. Okay, because those are investigations that help us to refine our diagnosis even further. Okay, then you can mention all other investigations. So outline the management of this patient. So again, when it comes to a patient like this, there are a lot of problems, and they are asking the management. So once again, it is better to come up with a problem list. So in our problem list, she definitely has an LVF. You can also divide into acute problems and chronic problems. So acute problems are definitely her left ventricular failure is an acute problem. The fact that she's having an ACS is also an acute problem. Okay, and then the fact that she's anemic at hemoglobin 7.6 is also somewhat a problem. Okay, because we have to correct the anemia also, because that might be precipitating the heart failure, and her elevated BP is also a problem. So those are 4 acute problems that we have to manage.
we have to manage acute. And then we can talk about the long-term aspects of the long-term management of the patient. So in long-term management, we have to mainly manage now her ischemic heart disease situation, her diabetes, her hypertension, and maybe now she might be having an entity of chronic heart failure also. Okay. Yeah. So acute management, talk about the settings and how to address each, how to address the ACS. You all know the answers already. We have discussed how to address the LVF, Chiranta discussed, anemia, anemia. So in this case, emergency correction of hemoglobin is blood transfusion. And hypertension management, we will discuss the hypertension. There is a class for hypertension, but basically something like IV labetalol or IV GTN is used. So when it comes to chronic management, I once again talk about the specialized clinic with the MDT approach. Yeah, one more important thing I didn't mention is now she is anemic now, and we are assuming that is due to NSAID use. So we have to see whether there is peptic ulceration or any bleeding from the GI tract. So endoscopy has to be arranged. And then the management of hypertension, and then at the same time screening for other comorbidities like dyslipidemia and whether there's target organ damage from hypertension and all that. You can write a complete answer. Okay. So that is the importance of importance of practicing SEQs and doing SEQs is like the more you do, the more things you will come up with in your management and the more marks you will get. Okay. So make sure you guys don't, when you guys are doing SEQs, make sure don't manage the problem which is just there, which is very obvious. Okay. So acute problems are usually very obvious. So think about the long-term management also. Then that will fetch you more marks. Okay. Yeah. So we will move on to CKD now. Anybody has questions regarding this? Someone has mentioned this how to easy way to remember areas of infarction in ECG. So there is no easy way. I sent a PDF called theory session 1 that has like a pictograph or some pictograph for area, the leads and the areas covered by each lead in an ECG. Okay, so we just go through that or remember that image. I mean, that's the easiest way, and that's how I also remember. Okay. So then, if there are no questions, we will move on to CKD. Okay. Okay. So CKD in a long case setting. Okay. So basically, in a long case setting, at a undergraduate level, we will get two situations. Okay. One is a patient, it's a new diagnosis. So the patient is presenting to the board the first time, and they make the diagnosis of CKD in the board, and unfortunately you are the candidate who will get the patient. So a new diagnosis of CKD is very difficult, okay, because they will have very odd symptoms, and especially if the CKD stage is very early, you can't catch a head or tail of the diagnosis. One clue to help you get a diagnosis is you have to ask them what they did in the board. Like, what did they do any ultrasound scan? Did they test the urine several times? Did they say there is protein in the urine several times? Did they opt for something like a renal biopsy? Did they refer you to a nephrological? Okay. වකුගඩු සම්බන්ධ විශේෂඥ ඩොක්ටර් දුස්සර කෙනෙක් බැලුවද? එහෙම like ask some questions like that, and then maybe you get a clue. Okay, and then build your case upon that. I mean, in my opinion, it's unfair to question, to give such a patient because they have very non-specific symptoms. Okay, otherwise, unless they have very end-stage CKD. And the other situation is, it's already a diagnosed patient presenting with a complication, or a diagnosed stable patient presenting to the exam. Okay, so rather than saying it's all like personally, I try not to give the diagnosis in the beginning. As soon as I talk about introduce the patient, I start talking about the patient. I try not to give a diagnosis because some examiners don't like. Because when you give out the diagnosis, then there is no case. There is no case to discuss. There is no mystery behind the case. So what I say is, if I know this patient is a CKD patient, I don't say CKD. I say something like a patient with a renal disorder presented to with blah blah blah. Okay. So I will just briefly go through the points in the history and examination that you have to highlight in a case of CKD. Okay. So I have colored the ones which are must know and good to know and nice to know stuff. Okay. So we start off with patient's introduction. So name, age, gender, and residence. So Anuradhapura and Kolam. I mean, not really applicable here, but sometimes if you get a patient from that area, you have to suspect CKD. And always ask about what the patient, the current problems of the patient. Okay, long-standing DM, long-standing hypertension, or already diagnosed patient with a renal disorder. Okay, so I will first discuss the easy situation where the patient is already diagnosed patient with CKD. Okay, so if the patient is already diagnosed with CKD, I have to ask when the diagnosis was made. Okay, and how the patient presented at the time of the diagnosis. Okay, and sometimes these patients, they will know their serum creatinine and EGFR values. Okay, you can ask, or definitely the examiner will ask you, did you ask the patient's initial serum creatinine and EGFR values? So you have better ask and keep. Okay, and then also ask change in the symptoms and the biochemical values over time. So in the creatinine value, and make sure you know the latest serum creatinine and EGFR values in the patient. Okay. And so once you cover up those, now you have the diagnosis of the patient and you know the trend, disease trend of the patient. So the next question is the etiology. So ask about how long they have had diabetes, how long they have hypertension. So diabetic patient presenting with nephropathy will definitely have retinopathy. So ask about the retinopathy. It will give you a clue that diabetes might most likely might be the cause of the CKD in the patient. So you ask about those diseases. Okay. And I will discuss more about it in the past medical history, like go into detail about the diabetes and then I'll talk about any investigations done up to now, ultrasound scans, renal biopsy, management at specialized clinics, blah, blah, blah. And then the treatment up to now. So medications given, how the response was, whether dialysis was done, the frequency, the type of dialysis, the response to dialysis, and when a transplant program was arranged, and if so, whether the donor is cadaveric or live, complications of the transplant and all that. And also, any complications of the CKD up to now. So you can ask about AKI on CKD. That's a complication. Can ask about metabolic abnormalities. Can ask about the anemia and all that. You guys can ask a bit about the complications of CKD. I'll go into details later. Also ask about the psychological impact and impact on the family. So basically, if you get up or any, actually not even CKD, any medicine long case, if the patient tells you the diagnosis right in the very beginning, you can follow this format. Talk about when the diagnosis was made, how the patient presented, any biochemical abnormalities, and the latest values. And then talk about the etiology for the diagnosis, talk about the investigations done for the diagnosis, talk about the treatment for the diagnosis, and any complications of the diagnosis. Okay, so you can ask these few questions, Taggala, and that will basically make up your HPC. Okay. Now we will go to a patient presenting for the first time, and we thinking about a diagnosis of CKD. So they can present with polyuria, edema, anemia, recent onset intractable hypertension. So there are some differentials you guys have to entertain in each. So polyuria and diabetes mellitus, hypercalcemia, diabetes insipidus. Unlikely you will get a patient presenting with polyuria and the diagnosis is CKD. Most likely the diagnosis most of the time is either diabetes mellitus or yeah, most of the time it's diabetes mellitus. Okay, or you can get a patient with generalized edema. So I think yesterday Siddiq did about CLCD. He must have discussed about this edema problem. So patient presenting with edema can be due to cardiac failure, liver failure, or kidney failure, or nephrotic syndrome, and then things like malnutrition and malabsorption. Okay, so you have to exclude these differentials. So way to exclude cardiac failure is, okay, ask about any previous cardiac insults, ask about orthopnea, ask about ankle swelling was during the day, and ask about other things like SOB and things like that. Okay, so liver failure, ask about jaundice, bleeding manifestations, encephalopathy state, ascites, things like that. Okay, and malnutrition and malabsorption basically ask about diarrhea and steatorrhea along with loss of weight. Okay, and so anemia is a big topic that will be covered by hopefully Tasneem next week. And recent onset intractable hypertension. So there are many causes for hypertension. So we will discuss that also at a later date. But basically, there are endocrine problems, vascular problems, cardiovascular problems, kidney problems also can cause hypertension, and then things like drugs, obstructive sleep apnea. So you'll have to exclude some of the causes, okay? In that. And so in your HPC, I told you like I gave a general format before, and the first one was a story, right? I didn't include in that. So in the story, what you really need to find out is the onset, progression, duration, and the associated symptoms. Okay, so when the patient is telling their story, you just interrupt here and there and just ask about, okay, එකපාරට දුනි ටික ටික දුනි and එන්න වැඩි වුණා and then කොච්චර කාලයක් තියෙනවා, then the associated symptoms. Okay, so associated symptoms, you need to ask about the uremic symptoms. So there is a long list. Okay, so remember just a few. Okay, so loss of appetite, lethargy, nausea, vomiting, paresthesia, things like that. Okay, now when you look at this whole picture, I mean, those are very non-specific symptoms, right? So it is good to know some of these symptoms. If someone, because sometimes they might ask you directly, okay, tell me some uremic symptoms, and then if you can list a few, that will be great. Okay. So a patient coming with these uremic symptoms, you will have to have some differentials, no? So some differentials are some sort of malignancy, some sort of chronic infection like TB, and an organ failure like liver disease. Okay, so keep those in mind also. Okay, talking about then in the HPC, after the story, excluding the differentials, then finding the etiology, right? So this is an easy way to remember. This is from the case book. So there are congenital causes. Then there is problems in the glomerulus. And there are problems in the tubes and the surrounding interstitium. And then there are problems in the blood vessels. And then there are obstructive problems like reflux nephropathy and urinary tract obstruction. So these are mainly surgical causes, and the other rest are medical causes. Okay, so you guys go through this list briefly, but this is an easy way to remember. There is a more extensive list in Kumar and Clark also. So whichever you all prefer, you guys remember, but remember you guys need to at least know this. Okay, and one other common cause of CKD in Sri Lanka is CKDU of unknown origin. So just remember that too. Okay. Yeah, and another easy way to remember this etiology is, okay, think about the structure of the nephron. So you have the glomerulus, and diseases in the glomerulus can cause CKD. You have your tubes, so diseases in the tubes can cause CKD. And there are a lot of blood vessels associated with the nephron, so the vascular disease. And then also just remember the urinary tract symptoms, system, and the surgical causes of obstruction. Okay. So you guys have to highlight some points in your history and try to come up with a cause. The commonest cause in Sri Lanka is long-standing DM or hypertension or that CKDU. Okay. in some, I mean, you might find instances where people with polycystic kidney disease presenting with CKD. Or there may be some instances where patients with multiple myeloma coming with a entity of CKD. Okay, but those are very like advanced and chronic patients. So they sometimes for the cases they get patients from other hospitals like Kalubovil, and also you might come across some very serious patients like that. Okay, so it's important to ask, did they find out a cause, and then just ask some questions in line with that cause. I think for peds, there is a boy who comes with some, I think you who has had UTI obstruction, I mean urinary tract obstruction, and now having CKD. He comes with erythropoiesis. Okay. So in your HPC story, differentials, etiology, and complications. So this is also from the case book. This is very summarized and brief. So remember some of the complications of CKD. Okay. So I remember GIT causes peptic ulceration and acute pancreatitis. CVS, remember it causes hypertension and heart failure, and also an increased chance of myocardial infarction and this uremic pericarditis. It causes anemia. Respiratory system, it causes pulmonary edema. CNS gives encephalopathy state. And remember endocrine amenorrhea erectile dysfunction. So remember, I mean, it's good if you can remember all. I mean, things like this, like studying lists, it can't be done in one day. So what you can do is just go through them as frequently as possible. I mean, the more you go through them, the more you will remember. So that's the only way. I mean, that's how I did it. I didn't study this whole list in one day. And because you tend to forget it, and I mean, it's better to know also. So if you do this, it's spaced out, then you guys will recall often, and there is better way of studying in my opinion. Okay. So after talking about the complications in your HPC, talk about investigations and treatment up to now. Basically, the ward management done in this admission. Okay. So if I go through it once again, so in a newly diagnosed patient, talk about the story. Patient will definitely have a story. Then talk about some of the differential diagnosis. Then talk about the etiology, and that also most of the time is diabetes. Okay, diabetes or hypertension. Then talk about some of the complications of each system. Okay, and then investigations and treatment up to now. Okay, so I mean, in a newly diagnosed patient, this is the part in your this is the part in your whole history that will give you a big clue to the diagnosis. Okay. So in the investigations and treatment, talk about the initial biochemical values and final biochemical values at the point of interview. Talk about the medication given, whether dialysis was carried out, and whether he was referred to some other specialized unit for a transplant. Okay. So that's it for the HPC. Then go on to the systemic inquiry. Okay, I haven't included that. Go to the systemic inquiry and ask about each system, and then talk about the past medical history. So diabetes, duration, follow-up, control, complications, and hypertension, all the same thing. Past surgical history. In your drug history and allergic history, important to ask about any nephrotoxic drugs. So say that patient is currently not on any nephrotoxic drugs. Okay. If you didn't even have time to ask, just say patient was not on any nephrotoxic drugs, because it's important in the management. And when it comes to a CKD patient, dietary history is also important. So easy way to take a dietary history is ask about the carbohydrates, ask about the fats, and ask about protein, and talk about salt restriction and vitamins and minerals. Okay, so that's like 6 broad headings. Talk about those things and how the patient was advised. Okay. I know sometimes there's like you can really, some people can really take you to town in the HPC. In a case like, I mean, if you have no idea what's like, I mean, by the end of the HPC, you need to have some idea of the diagnosis. Okay. So if the symptoms the patient tells are very non-specific, but you know to a certain extent that this can be CKD, because in the investigations and management done at the ward, it seems to be a case of CKD. Then just bat it as CKD, okay? And make sure you cover the important aspects to be mentioned in the other sections also. Like, for example, this dietary history and all is important in a CKD patient's management. Then talk about family history of any renal disease. Social history also becomes important in a CKD patient. So talk about, I have some 5 or 6 things you have to ask. So activities of daily living of the affected, ask about smoking and alcohol, compliance to treatment. And then in a CKD setting, you have to talk about affordability of dialysis, plans for transplantation, income, knowledge about disease, things like that, okay? And in your examination, so there is a whole list of things to examine in a patient with CKD. Practically, I mean, no one can remember all that and go. I mean, unless you have ample of time, which you don't in a long case. It's very difficult. So I have mentioned some few. So always mention the patient's BMI, because CKD patients, unless they are very edematous, they have loss of appetite, and their distinct build is not that good. So their BMI can be low. Talk about pallor, because anemia is very common in CKD. And now, if the cause is diabetes, check the eyes for cataract, or just, tell the examiner that you use the ophthalmoscope and try to see the eyes of the patient. See for signs of fluid overload, edema, and this dry skin. Mention about dry skin because that's also very common in CKD. But other things like this half and half nails, and those are like very theoretical things, and I don't know. I haven't seen any patients with true half and half nails. And then if it's important to mention whether the patient or has a fistula created. Especially in a short case, you can get a CKD edematous patient with a AV fistula. And they might ask, okay, what do you think the diagnosis is? So, that is an important finding. Sometimes they have this gout, swollen tender toes due to gout. And yeah. So those are some important things you have to find mentioned in your general examination. And proper CVS examination can make sure you check the pulse. The blood pressure is very important, and auscultate and see for any murmurs. Okay. Respiratory examination, just auscultate and check for pulmonary edema. Abdominal examination again becomes important. So look for scars, any renal masses, any renal bruise. DRE and vaginal examination in a medicine long case, I don't think they will expect you to do, but just say you will offer. And CNS examination also, if you have time, just check the cranial nerves, upper limbs, lower limbs, and that's it. Okay. Even if you didn't do it, mention in when you're presenting to the examiner as if you did it. Okay, because most of the time CNS will be normal. Okay, so that's the history and examination. Let's go on to rest of the investigations and management. So usually in an exam setting for us, patient is already diagnosed. So we only need to mention that small bit in green in the history. But the investigations and management of a CKD patient then will carry more weight, because there is nothing for us to diagnose. It's already diagnosed. Patient gives the diagnosis. So examiners will be interested in the investigations and management. Okay. So we'll talk about investigations first. So investigations in a case of CKD, first thing is to diagnose the CKD and assess the severity. And at the same time to find out the etiology and assess for complications. So that is the main aim of investigating a CKD patient. So a bit of theory to understand what investigations you do in a CKD patient. So CKD is defined as abnormalities of kidney structure or function present for more than 3 months with implications to health. Okay. So what are these abnormalities in structure and function we are talking about? So a functional abnormality will be detected by the EGFR, which is calculated using our serum creatinine levels. And structural abnormality is usually detected by the albuminuria. So basically when the basement membrane is damaged, protein will be filtered out.
and that is the structural damage to the nephron. And other ways of detecting structural damage to the nephron is abnormal renal imaging, like in diabetes, advanced diabetes, you get these contracted kidneys, and genetic disease. And if you do a renal biopsy, you find florid inflammation of the glomerulus. So that indicates a glomerulonephritis. And history of renal transplantation. Okay, so next question is how to calculate the EGFR. So it's done using the CKD epi formula, and it's usually using the serum creatinine values. So they can ask sometimes they can ask, okay, what are the things that increase or decrease the serum creatinine values in a patient? So Kumar and Clark has a table for that. So just go through it, okay? So then after, so what are the investigation to diagnose a patient with CKDs, the CKDs, the EGFR value and the albuminuria, okay? So staging of CKD is also based on the EGFR and the albuminuria, okay? So this is the KidGo classification for CKD staging. So as you guys can see, its 5 stages are there, and this is the GFR values, EGFR values, which is calculated using the serum creatinine, and this is the proteinuria values. So that also has 3 stages. Is everything clear to now? So if someone asks, how do you diagnose CKD? Okay, what you have to say is, so CKD is diagnosed with a structural or functional abnormality. So to detect a functional abnormality, we had to calculate the EGFR value. And to calculate the EGFR value, we need the serum creatinine value, the patient, along with the CKD epiform. And to calculate, to see whether there's a structural abnormality, we have to see the proteinuria or ultrasonically has to be demonstrated that there are abnormal kidneys. Histologically, it has to be demonstrated there are abnormal kidneys, or there's a history of genetic, the patient has a genetic disease of the kidney, or there's a history of transplantation. Okay. In an exam, if you get an CQ1 CKD and they ask for investigations, so the first investigation is serum creatinine and EGFR along with the EGFR. Okay, and then to assess proteinuria, you can do a spot sample, urine, albumin, and protein creatinine ratio. Okay. So you guys go through this lesson. So usually CKD starts from stage 3. Okay. Because they say, see this stage 1 and 2, they don't really progress. Most of them don't progress to end stage. So the real game starts from CKD stage 3. Okay. So sometimes the examiners will ask, what are the EGFR values for each stage? We will have to remember the EGFR values. And they might also ask the proteinuria values. Okay, if someone asks how to investigate proteinuria in a patient, so you can say there is you can use a spot sample where you see the urine albumin creatinine ratio, or you can do a 24-hour urinary collection. And there are so those are then there are dipsticks also which can be used to measure the protein levels. And then there are qualitative assessments like biuretes tests which can be done on the urine to get a qualitative analysis of the protein levels. Okay. So once you diagnose and stage CKD, the next is to assess the find out the etiology and complications. Okay. So etiology, so if it's a diabetic patient, then HbA1c is most definitive. And if there's heavy proteinuria in a UFR, then that suggests a glomerulonephritis. So, and to diagnose a specific glomerulonephritis, you have to do a renal biopsy and histology. And if there is an obstruction of the kidney, an ultrasound scan will show changes like hydronephrosis, hydroureter at the lab, the particular level of obstruction. And polycystic kidney disease will will show cysts, and you can use that Bosniak classification for kidney cysts. Okay, and then there are certain investigations to assess the complications of CKD also. So to assess the anemia, hemoglobin, to assess the acidosis levels, see bicarb. And then there's this CKD bone mineral disorder. So to get a picture of that, you need to do serum calcium, phosphate, ALP, and parathormone levels. And this is abdominal X-ray for abdominal aortic calcification, which happens in CKD. 2D echo for valvular calcification. Okay, so these are some investigations you can do. So in an SEQ, if they ask, okay, in an SEQ, you think this patient, the clinical picture is given, and they ask how do you investigate the patient. So you guys can divide how to diagnose and assess the severity. You can do EGFR along with serum creatinine and EGFR. And you can do a urine albumin creatinine ratio, and that will give you the diagnosis and will stage the patient. To find the etiology of the patient, can do if it's you suspect the patient to be diabetic, HbA1c. You suspect the patient to have a glomerulonephritis, UFR for proteinuria, red blood cells, red blood cell casts, and if casts are positive for dysmorphic red blood cells, renal biopsy, and if you are suspecting a surgical cause, then maybe ultrasound scan. If you're suspecting polycystic kidney disease, again ultrasound scan, things like that. And then when you are when you have to do some certain investigations, find the etiology, complications. So full blood count, serum bicarb, serum calcium, phosphate, ALP, parathormone levels, 2D echo for valvular calcification, things like that. Okay, so you guys can come up with a lot of investigations for CKD. Okay. Okay, so what are the complications of CKD? I'll just mention this. So anemia, hypertension, metabolic acidosis, hyperkalemia, uremia, salt and water retention, cardiovascular disease, and CKD bone mineral disorder. Okay, so they will sometimes ask, what are the causes of anemia in CKD? So there is a nice table given in Kumar and Clark of causes of anemia in CKD. Just go through it and remember some. Okay. And they might also ask about the CKD bone mineral disorder. Okay, so I don't think anyone will ask the pathogenesis of CKD bone mineral disorder unless you're doing a very good job, then to give you extra marks or something like that, they might ask. But basically, what happens is, I tell it very briefly. So what happens in CKD is phosphate excretion from the kidneys reduce. So there is this growth factor called fibroblast growth factor, which is released to increase phosphate excretion. Okay, so when that is released, it increases phosphate excretion in the urine, but at the same time, it reduces the enzyme 1-alpha hydroxylase activity. So which is important for the hydroxylation of 25 hydroxycalciferol, because and the whole, end result is there is not enough vitamin D produced in the body. So when there is not enough vitamin D produced in the body, there is less absorption of calcium from the gut. So that will result in low calcium levels, which will be detected by the parathyroid. Then they will start secreting parathormone to try to increase the calcium levels in the blood. So that results in the calcium in the bones being moved to the blood. So that's why you get all these rugged jersey spine, pepper pot skull appearance, things like that. Those are those radiological changes because of the calcium reabsorption into the blood. and you can tend to get things like fractures, and bone pain. So basically, what you all have to remember is in CKD bone mineral disorder, the blood calcium levels will be low. The blood phosphate levels will be high. And the parathormone levels also will be high. And the ALP levels will also be high, okay? So those are some biochemical abnormalities you will need to know. I don't really think they will ask the pathophysiology. So moving on, the management of CKD. So when they ask about, CKD is a very complicated condition, and ideally it should be managed by a specialist. So at the undergraduate level, they will only be asking the essence, the principles of management. Okay, so and CKD isn't something which can be managed acutely unless the patient is presenting with an acute complication. In that case, we manage the acute complication first. For example, a patient presenting with pulmonary edema, you manage the pulmonary edema with furosemide, and then we later deal with the CKD. Okay, so we always talk about multidisciplinary team and preparing the patient for KT transplantation in end-stage CKD. Okay, so in any management, goals are important. So first thing is to delay the progression of the CKD, because CKD after stage 3, there's a chance it will progress to end stage. Okay, so one thing is to delay the progression. Second thing is to manage, ideally prevent, and if any, manage complications. Okay. Third is preparing the patient for kidney transplant. Okay. So what are the methods of delaying progression? Okay. So if the patient is on nephrotoxic drugs like NSAIDs, stop there. Avoid hypoperfusion. So basically avoid a hypovolemic state in the patient. Okay. If there is any obstruction to the urinary tract system, example in males, is BPH, relieve that. And if there is an entity of any glomerulonephritis, so then immunosuppression therapy is indicated. So other general things we can do. So these are things which are actually done in the clinics. Okay, so blood pressure control, glycemic control, anti-proteinuric agents like ACE inhibitors and salt restriction, protein, protein. Anyway, okay, one important thing is anyway the Sri Lankan diet is deficient of protein. So what we advise patients is to take the normal protein levels. Okay, you don't tell them to take less protein. And at least 150 minutes of exercise per week. Stop smoking and stop nephrotoxins, and correct any metabolic acidosis and dyslipidemia. So if you mention this, these things, these things are things that a normal house officer can do and should do. So if you mention, even this part of the management, then okay, because then the rest of the things are like managing the complications. So managing complications of CKD. So if the patient present due to salt and water retention, they can present with hypertension, edema, or pulmonary edema. So at that point, the management is basically to restrict the salt, start with a loop diuretic like furosemide, and maybe add a thiazide diuretic also. So when the patient is on diuretics, you have to be mindful there can be electrolyte imbalances like hyponatremia, hypokalemia, and postural hypertension. So you shouldn't over diurete the patient. Okay. Then hyperkalemia is also a problem that can result in cardiac arrhythmias. Okay, so ECG monitoring. A patient with CKD coming with an acute complication, ECG monitoring is a must. In hyperkalemia, you get those tented T waves. So how do you correct that? So emergency management of hyperkalemia, even this time for a proper paper, there was a question. So that is very important what to do. So I won't discuss that, but you guys should read up. That's very important. So how to prevent hyperkalemia is low potassium diet, correct acidosis, potassium binding resins are there, loop diuretic, and so this consider stopping ras blockade, like tell it last, okay, because these ACE inhibitors and ARBs, they are used for their anti-protein uric effect, but at the same time, they tend to aggravate hypercalcemia. So say those things last, okay, because those are like advanced stuff. And some examiners might actually get mad if you talk about stopping ACE inhibitors and ARBs in a CKD patient. Okay, so correction of the metabolic acidosis. They aggravate CKD progression. They cause this renal osteodystrophy and muscle catabolism. So oral sodium bicarbonate is the answer for that. And so then the CKD bone mineral disorder. So it's a big topic. Okay, so I mean, don't spend too much time studying everything about CKD bone mineral disorder, because that's just a small entity of CKD. Okay, so what I recommend is just remember the biochemical values of the CKD bone mineral disorder, and then just address your management based on that. Okay. So since the phosphate levels are high, serum phosphate levels are high, we have to reduce phosphate. So that's mainly by diet. And you know, these things like there are phosphate binders, so you can mention a few. And if there is a vitamin D, now this low serum calcium is due to vitamin D deficiency, so correct the deficiency. And to correct the high PTH levels also, so you will have to supplement the patient with calcitriol. And also it is important to avoid hypercalcemia in so now when the problem is, okay, this is something advanced, like when you supplement the patient with vitamin D, then the calcium levels, or I mean, when at one point in the CKD mineral bone disease, like the calcium levels in the blood will increase and create a state of hypercalcemia, and that is bad because it has high levels in the high blood levels, blood calcium levels has an adverse effect on cardiovascular system. Okay, it increases the cardiovascular disease progression. So I mean, already in this condition you have high blood calcium levels, and you start adding it vitamin D, it will aggravate the hypercalcemia more. Okay, so the management of CKD bone mineral disorder, it's a very advanced area, and usually at an undergraduate level they don't expect you to know the nitty-gritty of it. Okay. And then the management of anemia. Okay, this is something that is important for us also to know. So remember, target hemoglobin is between 10 to 11.5. And if they ask, okay, how do you manage anemia as a complication in CKD patient? So first thing is to exclude all other causes of anemia. Okay, because we don't know whether anemia is due to CKD or there might be another cause. So that includes doing that full anemia profile. Okay, and if there is an iron deficiency detected, you have to first correct the iron deficiency. There's no point giving erythropoietin to a CKD patient with iron deficiency. So first correct the iron deficiency, and then you talk about erythropoietin, giving synthetic erythropoietin. Okay. And they might ask, so problems with erythropoietin, so they increase, I mean, some cause elevated blood pressure, no? It's an adverse effect. And then the other complication is infection risk. So you can provide vaccinations to patients to prevent infections. Okay. So that's basically management of CKD. So what I recommend is first, I mean, don't try to study CKD in one day. Study it over several days, and have a like a certain like a blueprint on what topics you will talk about in the management. And that way it's easy for you to remember, and it's not like information overload, because like there's a lot in medicine to read up on, and anything can be questioned also. So the best way is to know something about everything and not too much about everything. Okay. So any questions about CKD? And next week, I think Chiranta will be continuing the shortness of breath class, and it will be on asthma and COPD. And Tasneem will be doing approach to anemia as a long case. Okay. And then after next week, we will again discuss some SCQs, GIT SCQs, since Siddiq did a session on CLCD. I mean, that CLCD is like 70% of medicine GIT. Then towards the latter, I heard Vinula told that you guys want cases, but clinical cases practice towards the latter part. So we'll do that then. Okay, any questions? And I will send the CVS documents again in the supplementary group since some people have asked. If there are no questions, I'll end the session, okay?
Thank you, Matish.
Yeah, okay.